Again, read your rubrics, follow your rubrics when you're completing these assignments so you don't lose any unnecessary points. So with that being said, I'm going to go ahead and jump into week 5 now. So I'm going to share, I'm going to put the PowerPoint up. Like I said, I'll get you guys another PowerPoint, but this is what we have to use for today. So again, the topics for discussion this week are going to be your hospice and palliative care, your death and dying, faith and spirituality, and ethics. All right. So there we go. So who has heard of hospice before? Okay, so who can tell me what the main premise of hospice is?
Comfort.
Comfort, right? It's comfort and it's death with dignity, right?
And like there's no cure to like the person's disease or whatever.
Right. So we are going to keep them comfortable. We're going to maintain their dignity as well as their self-esteem. And with us as nurses, has anybody thought about going and working in hospice?
No. My resident that I have now is on hospice care, and I don't like how much agony she is in. I don't
How
like.
much what?
I said how much agony she's in. I don't like looking. Like it's nothing that I can do for her pain. I have to go in and change her and things like that. And when I'm touching her, it's hurting her. Um, she's
Are
in
they
her final.
providing with enough pain control?
I don't know because I don't deal with that part. She does have like hospice people that it's our clinical group, but she does have like a separate hospice care team that comes in there, but I'm usually not in there when they're doing whatever. I'm just there getting her changed and washing her up and all that kind of stuff. But as I'm doing it, I can see the grimaces on her face, and it's just not something that I would want to do. I don't want to watch people die, and it's nothing that I can do to help them.
Do to help them, yes.
I've thought about it just because like the process of death is interesting. Like not like, oh yeah, people dying is cool, but like, there's a process to it. And like people respond to it differently, like based on like their spiritual or religious beliefs and like who they are as a person, I feel like.
Right, right. So hospice is most of the hospice nurses that I've met have been absolutely amazing. And some of the ones that I have dealt with, both in practice as well as personally, because I did work with the hospice nurses with my mom and my mom's hospice nurse. We actually had gone through a couple hospice nurses before we found this one, and she was great. And so you're, just like, Nishane, like you were saying, sometimes maybe the nurse isn't a good fit for the client, and we have to kind of look at it that way as well. But the goal is, right, to keep them comfortable, to maintain their dignity, to maintain their self-esteem. And there is, we want to keep them, we want to try to get them as pain-free as possible. But we also don't want them sedated, right? We still want them to have some quality of life. They should be able to interact with their family. They should be able to, still make care decisions if, obviously if they're alert and oriented. But the client's needs are going to be the most important here. And the goal is to alleviate as much suffering as possible with hospice care. And it is also accepting that death is normal. It's expected. And we are humanizing that experience for them as well as their family. And even though family is a big part of hospice, right, we do include family. We do have to just remember that the patient or the client, that is our main focus. And so with hospice, all aggressive treatments are stopped. Your chemo, your dialysis, your ventilatory support. I'm trying to think. Sometimes you will see they'll still be on the oxygen or they may still get some IV fluids. Usually that's going to be a patient that's going to be a patient decision, if they should, if they want those things. And again, the goal is just quality of life rather than the quantity of life. And what can we do to kind of make them feel, a little bit more kind of in control. Um, and so hospice itself can be done anywhere. You can do hospice at home, you can do it in the hospital, they can do it in long-term care, hospitals even. There are even hospice houses. Um, and this is gonna sound really strange, and I've never heard of this one before. So I was talking to the person that delivers our medications to the facility. Um, and he was saying that there are actually hospice agencies that will rent hotel rooms if the family doesn't want the patient or the client to die at home, or in the hospital or whatever reason. They'll actually rent hotel rooms and have hospice in the hotel rooms, which I thought that was another interesting thing. Um, but there's
That is
some,
interesting because you don't know how long they have. Like,
yeah,
mm,
yeah, I was just thought, like I said, I thought
that's
that was
expensive.
interesting and I had
They
never
gonna be
heard of that
expensive.
before.
Yeah.
And I was like, and you're right. Normally, in order to go into hospice, right, you have to have a terminal diagnosis, usually 6 months or less, right? Or it's usually 6 months or less. And it's a terminal diagnosis. And they have decided, like I said, that they are going to stop all of those aggressive life-saving treatments are going to be, they're going to stop. And you're right, even though that terminal diagnosis says 6 months, people can live for 2 years, right? Or they can live for 1 month. We never know really how long that, how it's going to progress for them. So like I said, I'm still trying to find out some more information about that because I thought that was really interesting. Um, so yeah, again, pain control is going to be one of the big things that we worry about. Um, and we want to try to keep them, as comfortable as possible. What's the difference then between palliative care and hospice care?
Palliative is like improving the quality of life, even though like I don't know. I thought I knew. But like
No, I
there's
mean,
I
no
don't think
cure,
it's terminal with palliative care. It's not terminal.
but there's still no cure, right?
Yeah. But so it's another level of comfort, but just it's just your diagnosis is not terminal.
Yeah, yeah. That's
right.
what I do.
So we can do palliative care with hospice, okay? But we can also do palliative care with other disease processes. So think of, just to give just a generalization of what palliative care would be. It could even be just giving IV fluids, just to keep, get hydrated after somebody's had chemotherapy. Okay, so palliative it's just a helpful thing. It's improving their quality of life, it's alleviating their suffering, and it's, um, helping them to, move on. So palliative care can be completely separate from hospice, or it can be done with hospice. Okay. But with palliative care, they may still be receiving life-saving treatments like chemotherapy and radiation and having surgery and going to dialysis and all of that stuff. Whereas hospice, that generally we have already cut all of that out. Um, and so, with that, the goal of palliative care is to improve the quality of life while dealing with a life-threatening illness by reducing or relieving the symptoms of the disease. Okay, so that's the difference between palliative care and hospice care.
So basically,
So,
like interventions or not.
yeah, interventions. Yeah, absolutely. Um, and so some of the nursing care, the social support, the psychological support, the spiritual support that we can do for those that are in hospice. So your physical support stuff would be like your pain relief, right? Alleviating their pain, reducing air hunger, right? By putting them on oxygen to make them more comfortable. Could also be the use of medications like Ativan or morphine, um, improving their sleep. Social support, it's helping to improve strained relationships, right? So, one of the things that, um, people say when somebody is dying, they kind of are holding out, right, for that one person that they may have had a strife with at some point, and they feel the need, there's still that need to reconcile, right? And so, how do we kind of help them with that? um it could even be helping them update their will, or helping them to say goodbye to loved ones. And then with the spiritual support, finding peace, right? Whether it's with God, whether it's with their higher power, however we can help them do that. Um, the stages of grief: denial, anger, bargaining, depression, and acceptance. Has anybody heard of those before? So most, everybody kind of goes through those stages. Not just the client, not just your patient, but the family will go through those stages. Um, and denial is always the first, right? The tests are wrong, they made a mistake. They have to run the test again. They read it wrong, right? Denial is, always going to be that first one. And anger, right? That's the lashing out. The bargaining is, I'll go to church every Sunday if you just let this, if you just let me be okay. Um, and then the depression stage. And during that depression stage, they may need to see a mental health professional. And once they get to that acceptance phase, you can tell, when you're working with some of these patients. Um, and so, we have to just make sure that, I'm not a hospice nurse. I never will probably ever be a hospice nurse. However, in my chosen field, with geriatrics, and even working in pediatrics, I have had to work with pediatric hospice nurses as well, which, I think if I had to choose, I'd rather work with adult hospice nurses rather than pediatric hospice nurses. But it's always, those open-ended questions, right? We don't make assumptions. And that's why when you guys talked about that quiz question, I was like, oh, you're right. That quiz question doesn't make sense. Let me take it under review. Um, because not everybody believes in God. Not everybody wants to have a pastor. So I will look at, it's always, just whatever therapeutic communication, allow patients, families to talk it through, um, ask those open-ended questions, about what they want and what they do. Does anybody know, before we move on, does anybody know what are some of the changes? What are some of the things that you are going to see as a patient or as a client is getting ready to die? Has anybody worked with a dying client before?
Yes.
We're at a clinical site. There was this lady that was dying, and like we got some education, but not a lot. But like their breathing was like,
It's the gurgle or something, right?
Yeah, the Cheyne-Stokes respiration, we call that the death rattle.
Oh, rattle, that's what it is. I know it was
Yeah.
something like that.
So they start sleeping a little bit more. They may stop eating, they may stop drinking, and with that, their urine output is going to decrease as well. They also may become incontinent if they've been continent before. They'll become tachycardic, their blood pressure will drop. The extremities, the skin on the extremities will have like a mottled look to it. They'll start to feel cool to the touch. And that's because blood is just going to the major organs at that point. And again, they'll have those Cheyne-Stokes respirations, which unfortunately probably not the best word for it, but that's what we do call the death rattle.
Don't you start to lose your hearing too?
The hearing is the last to go.
Oh.
The hearing is the last to go. So it's something that we always tell our patients when we have a client that's passing, is to talk to them, tell them a story, read them a book, sing them a song, tell them how much you love them, whatever it is, right? Because they say that hearing is the last sense to go. And so we want them. That's why we, even as instructors with nursing students, right? Even if the client is unresponsive, right? You still go in and you talk to them. If you're going to have to, if you're going to perform a procedure, whether it's a Foley catheter or a blood draw, whatever it is, right? You're going to still talk to them like they're alert and awake, right? Even though you're not going to get a response. And with that being said, we should probably be careful with some of the things that we're saying around them as well, right? So yeah, it can be draining. Like I said, I've met some really wonderful hospice nurses that, they've been doing it for a long time. I don't know how, because it can be mentally and probably physically draining. And you probably have to have a really good deep set faith or some belief, I should say, to kind of help them through that process. Which is going to lead us into faith and spirituality as well as culture. So cultural competence. So what does it mean to be culturally competent?
I guess knowledgeable of other people's cultures or
Okay.
understanding of it.
And
Okay.
your own, right?
I'm sorry?
And your own, like
And your own. Yeah, absolutely. Right. So we have to have an understanding of our own culture, right? So we have to know our own culture. And that allows us to identify any potential biases, any stereotypes that we may apply to somebody else. And so, right, absolutely. We have to understand our own culture as well. One big thing is we always approach every person as a unique individual. Okay. We don't make assumptions. We don't put our culture above anybody else's. And that, one thing is with that, you may have, a person that is of one culture, but they may not practice, right, all of the traditions of that culture, right? So it would be an assumption, right, or a bias or a stereotype, right, to say that they participated in that. So I'm trying to think, like, so I'll just use myself. I'm Polish, okay? I'm a Polish Catholic. My grandparents came over here from Poland back in like a long time ago, because then I'm not going to tell you how old I am, but let's just say a long time ago, okay? Um, and very strict Polish Catholic growing up. And that is how I was raised. But as I became an adult and I moved away, I don't practice any of my Polish heritage. I make some of the food, okay, but I'm not immersed in that. Right. So if somebody, were to ask me and I was like, yeah, I'm Polish Catholic, and they would start asking me things. I probably wouldn't have a clue what they were talking about. Okay. So everybody is unique. We're going to identify everybody is unique person. It doesn't matter what culture or what ethnicity they are all unique. So what is the best way that we can identify what their cultural needs are?
Asking.
Ask them.
And if they're not like able to like explain it themselves, ask their family.
Yeah. So ask them, right? That's the best way to find out about somebody is just to ask them, right? And if you're not now as a nurse, you need to be very inquisitive, okay? Ask all those questions. That's one of the great things that you can, I still do this, and I've been a nurse for a very long time. If something kind of, if I'm having a conversation with somebody or I see something, I will walk up to that person and say, look, I just have to ask. And I'll always throw that, I'm a nurse. This is why I'm asking, just out of curiosity. So it makes me a little less weird, right? When I walk up to random strangers and ask them odd questions. But yes, ask them. So remember, everybody's an individual. We're going to ask them. Um, Cultures are oriented to the past, the present, or the future. And so what this means is some of our some cultures are past oriented, meaning they look towards their ancestors and the past. And in some cases can even have a preoccupation with the past that makes it difficult for them to achieve future goals. With your present oriented cultures, they live in the here and the now. Okay. They prioritize quality of life and making decisions that are making them happy right now. The problem with that is they don't plan for the future or consider future consequences. Whereas then on the last part of that, with our future oriented cultures, they're more likely to make sacrifices here in the present in order to achieve their future or long-term goals. So cultures are all going to be different. So and again, with all of this is just making sure that we approach each client as an individual, that they are unique. We gather data that is specific about them and their beliefs and their expectations, their needs. Not everybody is treated the same. And, I should say that justice is one of our ethical principles that says that we treat everybody the same. But when it comes to culture, it's not assuming, I guess is what I'm trying to say, right? Just because I'm a member of a specific culture does not mean that I'm going to practice all of those parts of that culture. And so you obtain your cultural competence. This last line right here is attain when you make a conscious attempt to learn about people of diverse cultures and look at the world through their perspective. And so, you can kind of look at your communities and you can see what some of the more dominant cultures are in your communities. You can learn about some of the dominant cultures and get some basic information about those cultures, right? But the best way is always going to be to ask your individual clients what their preferences are. All right. So then we have our wonderful faith community nurse. So a faith community nurse or a parish nurse is a specialized nursing practice. It's most commonly or it's more community oriented than community based. So they generally will work within their congregation or their faith-based community. So they're usually volunteers or sometimes they're hired by churches or religious organizations. And they do have to go, there is a scope of practice for your faith community nurses. There's, There's education and training that they need to undergo. But their practice is built on health education, health promotion, coordination of community resources, all while still incorporating that spiritual health and those religious practices. So I actually have a nurse that I used to work with. She had, she went back and she got her master's in religious studies, is what I think it was. And she retired as she worked her we worked at Children's Hospital together. She retired and she went into parish nursing. So she worked with the local church, and they would go out, she would volunteer at the hospital, but she would also go and she would go to people's homes, visit the sick, those that can't get out of the house. Um, as well as offer classes at the church about health promotion, and health education. She's also very big in the community. So she was able to meet and greet, and identify resources that are available within the community for members of her of her church, should they be in need, whether it was help with the bills, help with finding food resources, transportation, right? So that, where they kind of work within their congregations or their religious organizations. Um, and again, this is all, it's that holistic approach, right? Body, mind, and spirit. So, we kind of just take it in, they can help them with acute illnesses, chronic illnesses, even, like after the birth of a baby, after the death of a family member, or a loved one, right? They can go in and they can provide those supports to them. Another really big thing that kind of we pull into that is this whole spirituality versus religion. So, spirituality and religion, and a lot of times we use those terms interchangeably, but they're really not. Religion is more tradition. You're a member of a church. It's a more structured organization, right? So Catholic, Jehovah Witness, a Pentecostal, a Baptist, and forgive me because there's, a lot of different religions out there, right? But they're a member of that congregation, they're part of that church, they're active in that church. Where spirituality is more of a, I guess, well, it says attitude, so it's our attitudes related to a higher power. And so, most people will believe in some sort of a higher power, whether it's, whatever they call it, God, Allah, there's a variety, Jehovah. But they also, there's others where even just taking a walk in nature, or reading spiritual passages, or listening to music, right, can help them with their spirituality. It's not always I have to go to church on Sunday, or I have to go to church to pray. They find more comfort in just knowing that there's a higher power, and um I guess exhibiting that in their own different way. You can be religious and spiritual, but for most part they are kind of separate. um a lot of people have more spiritual beliefs than they do, than religious traditions. But either way, whether it's spirituality or religion, incorporating that into the patient care can help to provide some comfort to our patients. Um, that it just, especially in times where, of acute illnesses, of injuries, of traumas, or any kind of, bad news or devastating news, having that spirituality or that religion to kind of fall back on to help support them, right, is much needed in many people's lives. So we need to kind of assist them through that process. So any questions on spirituality versus religion? All right, so it's going to bring us to ethics. Okay, so whoops, I just kind of like flew right through that. So, what is ethics? What is ethics?
And like doing what's right and wrong, I guess.
Okay, so it's doing what's right, it's right or wrong. And so when we look at what is an ethical issue, so what is an ethical issue or an ethical dilemma?
So could you use like a blood transfusion as one? So like you know how just I don't know. You know how
Like
Jehovah's
Jehovah
Witnesses, yeah,
Witnesses?
like Jehovah's Witnesses, they don't like it. Like sometimes ethically people want to go against it and still treat the person, but it goes against what the person believes in.
Okay, okay. I can accept that as a good one. Yes.
Or I was thinking like, it's like you're not supposed to give out like private information to patients like about yourself, no matter how much you want to. Like, let's say, I don't know, you think like the client is like so cute and like you want to like talk to him or whatever. Like, you can't
Okay.
do that. You know what I
No,
mean?
you can't do that. You can't do that. You're absolutely right. But yes, okay, so that would definitely be an ethical issue. That could also probably go on a moral issue too, right? So it can kind of follow that. But there's, I mean, and there's going to be ethical issues that unfortunately we are going to face as future nurses and in healthcare. Um, and the best thing to do with your ethical dilemmas or your ethical issues, kind of both, use that nursing process to help you along, right? You want to identify you want to identify what the issue is. You want to you want to collect all the data about it, all the facts. Then you want to, sit down and we want to look at interventions. What can we do to, approach this ethical dilemma? Then we want to make that decision and implement the action. And then we go back and we evaluate, well, did it work or did it work? Um, so those are some ways to address ethical issues. Um, we have ethics committees. And that's one thing that kind of helps us along. The purpose of ethics committees will help process those ethical dilemmas. They also provide education, they review policy, as well as, case by case consultations. Um, so an example of this, um, you know, um, like an ethical dilemma would be, do we provide care for, do we provide the same level of care for an aging individual that we would for a younger individual in the similar situation, right? So, we have two people, let's say we have a son and his old elderly mom, they had it, they had a car accident, they have similar injuries. Okay, we know that he's younger and he's more well fit and she's older, she's more frail. Do we provide that same level of care to both?
We were just talking about that in one of our classes, kind of sort of. We had a discussion about transplants and who to give an organ to. Like, are you going to give it to somebody? Well, they were saying, okay, so who did you use? Sarah Frank Gallagher, from this show called Shameless. He's like a drinker.
Uh-huh.
She was saying how they gave somebody a liver that constantly drinks as opposed to somebody who didn't drink, or but
No,
I
I
guess.
wasn't saying that. I was just saying like Frank Gallagher, like, like you wouldn't
Really?
like recovering alcoholics, like Mr. Michael was saying, like recovering alcoholics, they don't like to give it to. But I was saying like, it
Oh, that's what it was, recovering alcohol.
every case would be different because like people get sober, just because like they have a bad past doesn't mean they don't deserve, to get better, like have a
Right.
better opportunity, like better quality of life.
Right, absolutely. Yeah, so that could, I mean, that's definitely like, how do you make those decisions, right? Who gets it? It's like, what do you do? Flip a coin? Like, how do we do that, right? Um, So that's, that's one of those wonderful things about those ethics committees that are available, is that, we had, everybody kind of takes all of the facts into consideration and makes those decisions. One thing that we do have to talk about here too is moral distress. And so moral distress kind of falls under this. I don't know if it's on the next slide or if that it is. Moral distress is when somebody is not able to act according to what they believe to be the right course of action. And it can be, it may be something that comes up at some point in your career. So things like some things that could cause moral distress would be end of life decisions. It could be visitor restrictions. This was one for me. And I will tell you, I worked a COVID unit during COVID. And we had a client that was actually actively dying. And because of the restrictions on visitors, they weren't going to allow the family members to come into the building to say goodbye. And that was a huge moral dilemma for me because I felt like, yeah, I understand COVID. I get, the danger and all of that, but they're never going to see their loved one again. They should have the right to come in and say goodbye to their loved
Or
one.
if it was you and it was your family member, you would want to go see your family member.
Exactly.
Yeah, a lot of
So,
happened during COVID. I know that like my grandpa was dying in COVID and like we weren't able to have like a funeral for him, or like when he was like actively dying, like nobody was able to go see him because of COVID.
yeah. So that, that was definitely a big moral dilemma that caused a lot of distress during COVID. Beneficence means to do good. Okay, so we do the most good under the circumstances. So we are talking about our hospice care, right? Beneficence would be providing that adequate pain control to our hospice patients. Um, Justice is, right, we are providing this equal care to our clients. We also have something called distributive justice. And distributive justice is part of advocacy. So this is, we're advocating for our clients. And don't look at my slide. I just realized I spelled non-maleficence wrong. Don't judge me. Um, then we have non-maleficence, which is to do no harm, right? So, we try to make sure that's why we practice our rights of medication administration. We do our 3 checks to make sure we're giving the medication appropriately, that we don't perform procedures, right, that we don't know how to do or we haven't been trained on equipment, right? It's all about not doing harm. Autonomy is respecting their client's wishes. So again, I just go back to hospice care since that's the topic of the day or one of the topics of the day when they decide to stop treatment, right? That's their decision. That's their autonomy. That's that's their right to stop that treatment. Um, and as nurses, as healthcare providers, right, we need to respect that.
So
Um,
I got a question with that. So say it's a child and they want to stop care. Do they go to the ethics committee or like one of those committees to
so
make a
yes,
decision?
yes. So there's another term, it's called what is it called? It's beneficent paternalism. Okay. And so generally with beneficent paternalism, the whole premise behind that is what I say goes. It's kind of like my way or the highway kind of thing. And we generally don't practice that. It's usually not a very good technique for caring for patients. However, okay, where we would consider that to be helpful or needed, is in that exact situation where the parents have decided that they don't want or they're not going to pursue life-saving, treatments for their child. The healthcare organization can submit for either guardianship, they can go to court in order to challenge the parents in that kind of situation. So yes. But with advocacy, we know that that's a huge part of everything that we do or that we are going to do as future nurses, right? It's the use of information and resources to benefit our clients, right? So the more information our clients have, the better off they are going to be, right? We also making sure that we're acting in the best interests of our clients, that we're maintaining their confidentiality, right? That we are then going to carry out, right, the preferences of our clients with diligence and competence. And, so it's just, it's making sure that as an advocate for your client, they have all the information that they need, whether it's signing an informed consent for a procedure, it's, helping them, and I don't know if anybody has worked in long-term care, but it could even be helping them fill out their Medicaid application to help get coverage, right, to pay for long-term care. I'm trying to think of what else. So it's just helping our patients and doing the best that we can for them. Or like I said, if they decide that they don't want to go through with life-saving treatments anymore, then that's also something that we need to respect. If we feel as nurses, and I'm going to stop sharing. If we feel as nurses that we cannot provide quality care to a client because of a moral distress or an ethical dilemma, okay, you can't just walk away from your clients. All right. So I'm going to use a controversial topic, and I'm going to use abortion as a controversial topic. Okay. So let's say you don't believe in abortion and you have a client that comes in and you're working in the emergency room and they had an abortion, a botched abortion, and now they have a huge infection and they need emergency care, but you don't believe in abortion. What do you do?
That's when you gotta check your biases, and they're still sick. I don't know. If they're still sick, you gotta take care of them. Like, we were talking about this in foundations and the beginning of med search. Like, you gotta check your check your
You got to
bias.
take your personal out of it.
Yeah, because it's not about you. Like, you got in this to help people who need it. You know what I mean?
What if you can't?
Then you gotta find somebody else who can.
Yeah, I want to ask one of your
trade.
colleagues.
Yeah, see if you can trade with someone.
Now you can say, but it's not always a guarantee. Remember that. Okay. It's not always a guarantee. So I'll use an example that personal, with one of the clients that I had to take care of. This client killed his family, his wife and kids, burnt their house down. um, and I don't remember when, at what point, so don't quote me on that, but ended up having a stroke and ended up needing long-term care, or skilled care. So avoided jail time because of that. And we had to take care of him. So we had to take care of him just like he was any other patient. You think of like we have all those, and I hate to talk about them, but like your school shootings and all these other maniacal people that are out there, right?
How
Doing
did
all
that
these
make you
crazy
feel
things.
going in there? How did that make you feel every day? That would literally make me sick to my stomach.
It's not easy, especially too, because this was a really long time ago and it was when my kids were younger and little, and if anybody would have hurt them, I probably, mama bear, right? It's very hard. And I'm not going to say that it's not hard. It is something that is difficult to do. But I'm going to fall back on my faith and my spirituality with that, even though I don't practice my religion. I'm still very spiritual. I just know that I took a vow when I graduated from nursing school to help people, right? And that is what I'm here for. Whether their actions were right or wrong, you know, I can't control other people's actions, right? I can't control their behaviors. Um, but yes, we did provide him the same care. He got the same care and respect that every other patient had. Um,
Have you ever experienced something when a patient didn't want you to treat them because of your skin color or something like that?
I've not been on the receiving end of that. Not
Because
yet.
it could go both ways. I
It
was
can
thinking it could go both.
absolutely go both ways. Can absolutely go both ways. And it's all, but I will tell you though, when it can go both ways, but it's not always negative. Okay. So we have to look at that too. Like I had students at clinical one time. It was an all-female group. I didn't have any male students. And there was a Muslim man that needed care, but females can't provide care to Muslim men, right? So it's not always a negative thing. Okay. So we have to kind of look like there's, it's just that's their culture, that's their belief, right? That's their way of life. And so it made it a little bit difficult. Fortunately, he had family members that were male that were able to come in and assist him with like showering and stuff like that, where, we wouldn't be able to assist him. So yeah, so you just kind of have to, it's not always negative. Some things are like, okay, well, that's just a cultural thing that we have to, work with. But there's not male CNAs and male nurses in every facility, right? So, we have to learn how to accommodate. So yeah, so our duty is to provide a standard of care to our client. And like, we talked about if it is, and ultimately, if it is something that we feel that we cannot do, then yes, if you can find somebody that can, take over the care for that patient or that client for you, then, you can always try. But just know that that's not a guarantee, and there still may be consequences of your actions should you not care for your clients. So just be careful with that. The best thing, like whoever said it, I don't remember if it was Sarah or if it was Nishay, but leave it at the door, right? Just leave it at the door. And just remember why you are doing what you are doing, right? Everyone has their own story as to why they decided to go to nursing school, right? And what they want to do. But the ultimate goal, right, is that we want to care for people and that we generally care for people. And that's kind of why we're doing what we're doing. So, and I have like 30 seconds to spare. So does anybody have any questions?
I wanted to go into corrections, but I feel like that's going to be the challenging part for me, not judging them based off of, because here I am, have a child rapist. Oh, I got dry eyes. Can I get some eye drops? I'm just like, you raped the whole child.
Yeah. So my mom was a corrections nurse. She worked for a state prison in Florida. Um, and so yeah, but you got to think if you want to do that type of care, you kind of have to accept, right? It's just kind of like working in a state psychiatric facility, right? You can have murderers and other things in those facilities as well, right? Maybe they don't have as much control over their situation, right, as to how they ended up there, but it's still very similar in, when we look at it, as a whole. And it's something to think about. Yeah, I don't know. Yeah, there's a different place for child molesters, I believe. I mean, but yeah, that is something that you would have to consider if you're going to go work in a prison or a jail. Because you don't have a choice over the clientele at all that you're going to deal with in those situations. There's no walking in off the street, right? It's what's in there is what you got. So All right. Well, it is 1:40, so I will let you guys go unless you have any questions, and I will get that PowerPoint out to you by the
Thank
weekend.
you.
Okay?
I have a question about the group 7 project. I mean, week 7 group project. So
Sure.
in the instructions, it says you will all need to submit the written paper. Each member will be submitting the same